I think it's an area which the community is debating right now. And I think that I think there are watershed data, in my opinion. We never had overall survival before. We were climbing up that hill. We now have overall survival and we're going down the other side. So I think that is a watershed moment. And I think that's true. I think the previous data sets where we showed disease-free survival that was statistically significant and clinically meaningful, with an OS trending in the right direction. And even at the beginning, the first data cut, our OS hazard ratio was 0.53. Now, the absolute difference in events was number of percentage at landmarks relatively small because we were talking about relatively few events, but we knew OS was trending the right way. So I think when these data came out, I don't think people were shocked that we hit overall survival because everything had been trending in that direction before. But it is true that we now have statistically significant overall survival. We've hit that endpoint. And so now when we discuss things with patients, the dialogue has changed. And that dialogue prior to these results were that we can reduce the risk of the cancer coming back by about 40%. We don't yet know if that means you'll live longer, because we could salvage you with subsequent therapy in the future, and you've got a 10% chance of life-changing toxicity. And in my experience, about half the patients said, that sounds good, and the other half said, oh, I'm a bit worried. I think the change in that dialogue is now moved to, and on top of that, we know that there is a significant increased chance of you being alive at these various time points moving forwards. And I think many patients will look at that and say, I want to grab that with both hands. So I would expect the proportion of patients who I speak to who choose to have this will increase from about 50% to probably about 70%, I suspect. I think first, we struggled to select patients for adjuvant therapy. And there were some questions at the end of Tony's presentation, which really focused on that. And they focused on, you're bringing a whole string of patients whose cancer is not going to relapse. You're treating those patients, they're clearly being overtreated to help that group who do relapse. Now, in the overall population, there are more patients alive, even when you overtreat those patients. And that's an important concept. So even despite that, there are more patients who are alive. And that's why identification of a higher and higher risk group is beneficial, not just because you've got an increased chance of those patients relapsing, but because those patients cancer relapsing, but you're not taking with you groups of patients at low risk. And that's really in no one's, it's in no one's interest to treat patients who don't need therapy. So the question is, are there better tools of identification of these patients? And I think we need to look at things like circulating biomarkers, perhaps better tissue-based biomarkers, identification of patients who relapse. But make no mistake, this first step in the journey, this moment in that, is a really important step towards that second and third step. I don't think in 20 years' time we're going to be giving unselected patients adjuvant therapy. I think we will develop those biomarkers. And I think those people who are critical, which I think is it's very important that when we do have watershed data, there is both sides of the discussion from a patient's perspective. I think that those people who are saying, we need to see more data about the patients who relapsed, I think those people are really saying what we really want is we want to better identify patients. Because I think we all believe, and I believe strongly, that treating patients at risk early with immune therapy is really important. Because we all experience this as the treatment journey is ongoing. Not all patients get immune therapy. Patients relapse with brain metastasis, or they develop complications of the disease that means they can't have targeted therapy or can't have immune therapy. Not everyone is going to get all the therapies. Not all patients get 5 lines of therapies in kidney cancer. Actually, when you look in the community, the majority of patients are only just making it to second-line therapy. And so this opportunity to grab that at-risk population and treat them early in the knowledge that they've had this therapy, and I think immune therapy cures patients in the adjuvant setting. I think it cures some patients in the metastatic setting as well. My deep feel is it's curing more patients in the adjuvant setting than the metastatic setting. I think the adjuvant setting is an easier place to treat, but we are bringing with us some patients who are not at risk and putting them in harm's way. As I said at the beginning, these significant overall survival data change the dialogue. They move it from things are going in the right direction to we don't know yet to we actually do know it is associated with survival. And as that occurs, we in the community need to think more carefully about what that means and how it affects our patients. Look, all of these regimes look very similar to me. And I wish we in the community talk more about management of toxicity. We talk more about treatment-related adverse events. We talk more about how we make sure patients have got great contact with healthcare professionals 24/7. Are they getting the best advice at the beginning of the journey that they can? Are we maximizing the treatment in terms of durability of response? Are we stopping the treatments at the right time? And these are all, for me, probably more important questions than the choice between cabo-nivo versus lenvatinib and pembrolizumab. And I'm not as excited about that discussion as perhaps some of my colleagues. Pick one of the four regimes, use it well. Ipi-nivo is probably less good at initial control of disease. I think that's true. The VEGF-TKI IOs have got the problem of long-term VEGF-TKI therapy. That's probably true. In the end, the survivals all look about the same. My advice is to the clinical community is pick one, use it well, get a good team around you, be experienced, educate, train. Yeah, I think that's fair. When do you not give the fourth cycle of ipi-nivo? How bad the toxicity need to be? When is it safe to stop the immune checkpoint inhibitor? What do you do with grade 3 transaminitis? Do you re-challenge? What if you get grade 3 endocrine toxicity, such as diabetes? Do you stop the drugs or do you continue? These are all much more interesting questions about whether cabo-nivo or actually pembro has got better data. How do you treat patients whose cancers has relapsed after adjuvant pembro? What happens if a patient gets grade 3 toxicity, but their cancer is responding very well in the first 2 cycles? Are they contraindicated? Do they need to have more immune checkpoint inhibitor? Is it safe to stop? Do you need CTLA-4 up front for some patients? These are all important questions, but the indirect comparisons of the overall survival hazard ratios for these regimes, which we're happy to debate, are inconsequential in compared to those other questions.